Right, good morning, everybody. How you're doing today? I'm not sure if you can hear me. Can you please let me know if you can hear me? All right, great. So can you see the two slides on here? So the PowerPoint slides on the left and the blackboard on the right side. All right, great. So for last class, if you remember, so for those who did not make it to our last meeting, so the sound was not recorded in the second half after break. So just to make sure that everybody gets the message on here. So the in-class activity from last time was to identify the lungs volumes and capacities from this diagram. A quick review of what we've discussed last class, if you remember. We do have an amount of air that moves in and out during rest, and this is gonna be my tidal volume. This is the amount of air that moves in and out of my lungs during resting conditions. So I have no problem with this. This is my tidal volume. I can breathe in maximally, so I'm adding much more air to the amount I'm already breathing during rest, which is the tidal volume on here. So the amount of air that I can breathe in beyond the tidal volumes is going to be my inspiratory reserve volume. Can I exhale more air than what I'm breathing out during rest? I can perform a forceful expiration. All this amount of air that I can exhale beyond the normal tidal volume, this is what we call the expiratory reserve volume. If you remember, after you exhale the maximum amount of air from your lungs did not collapse. You still have some amount of air that is kept in your lungs. Still, after you perform a maximal expiration, after I get the expiratory reserve volume out, I still have some air trapped in my lungs that I can't move outside of the lungs. This is what we've called the residual volume. So again, 4 volumes that we've seen. The tidal volume is the amount of air that you can breathe in, out during rest. It's a quiet breathing. I have no problem with that. Whenever I decide to run, for example, I would need extra amounts of oxygen. I need to breathe deeper. So the amount of air that I am inhaling beyond the tidal volume, again, is my inspiratory reserve volume. I can breathe out maximally. I can increase the amount of air that is moving outside of my lungs beyond the tidal volume. We call this as my expiratory reserve volume. Still having air trapped in your lungs after you perform a maximal expiration, this amount of air won't move outside of the lungs unless you've lost the intrapleural pressure, the negative pressures that keeps the lungs inflated. If you remember what keeps my lungs inflated was the effect of the negative intrapleural pressure. So if you remember, this was your lung pressure was equal to the atmospheric pressure. So my pulmonary pressure or intra-alveolar pressure is almost always equal to 0. All right, almost always equal to 0. What keeps the lungs inflated is not that you're pushing air in the lung from outside, but because of the suction force that you are applying to the lung itself from outside. Remember, around your lungs, you've got 2 membranes, and those 2 membranes, or 1 membrane with 2 layers, 1 layer is pulled out, 1 layer is trying all the time to move in. The visceral layer of the pleura is attached to the lung, so it tries to move inwards, and the parietal layer of the pleura is going to be attached to the chest wall. It's always going to be trying to move out. So I'm pulling the 2 layers of the pleura away from one another. This creates a vacuum in between, a suction force. And remember, this suction force was -4, around -4. So this means what? This means it's lower than the atmospheric pressure by 4 millimeter mercury. What keeps the lungs inflated was the difference between the pressure inside and the pressure outside. So if the pressure inside was a 0 pressure, it's equal to the atmospheric pressure. Outside, I have a vacuum. It's a negative force, -4 millimeter mercury. So the effective pressure is what we've called transpulmonary pressure. The transpulmonary pressure is equal to 4 millimeter mercury. This is my effective pressure that keeps the lungs inflated. And that's why you can't normally collapse the lungs. You can't normally get this residual volume outside of the lungs. I can't move this amount of air outside of the lungs. Also, if you remember, we've discussed the lungs capacities, and we mentioned that the maximum amount of air that you can hold in your lungs after maximal inspiration, after you perform a maximal inspiration, after you get all the air that you can in, the amount of air that can be held in your lungs, this was called my total lung capacity. The maximum amount of air that I can move in and out. How would I know this? You ask the patient to perform maximal inspiration first, and then to be followed by maximal expiration. Maximal inspiration, so I get to this point, and then I would ask him to perform a maximal expiration, dragging the volume of air in the lungs to the lowest point. So this is the maximum amount of air that I can actually move in and out of my lungs. We call this is the vital capacity. This is the living part, my vital capacity. The amount of air that I can inhale, generally speaking, after normal expiration, this is going to be the tidal volume along with the inspiratory reserve volume. So both of them combined is what we call the inspiratory capacity. As you don't get the expiratory reserve volume outside of your lungs for most of the time, so it's kept in your lungs for most of the time along with the residual volume. So actually, in most of the time, what is kept in my lungs is both expiratory reserve volume and the residual volume. So we call those combined together, it's my functional residual capacity. So again, what are the different volumes and capacities that we've seen last class? We've seen tidal volume, we've seen inspiratory reserve volume, we've seen expiratory reserve volume, and we've seen the residual volume. For the capacities, the maximum lung capacity is all the air that you can keep in your lungs after you perform a maximal inspiration. So all this amount of air that can be kept in my lungs is called my total lung capacity. How about my maximum amount of air that I can move in and out? So you ask your patient to perform maximal inspiration to be followed by maximal expiration. Maximal inspiration followed by maximal expiration. So all this together, inspiratory reserve, tidal volume, expiratory reserve volume, all the three together is what we call the vital capacity. If we're looking on here, most of the time you keep what in your lungs? Expiratory reserve volume and the residual volume. Both of them are kept for most of the time in your lungs. So we call those two together. Those are forming my functional residual capacity. The amount of air that I can breathe in is after normal expiration is simply going to be the tidal volume plus the inspiratory reserve volume. So both combined together is what we call the inspiratory capacity. Inspiratory capacity. All right. So again, the in-class activity from last class was to name those different lungs, volumes, and capacities. Any problem? Any problem? All right, so today we are starting our discussion of few topics that are related to the respiratory system before we move on to the digestive system. So first topic here is going to be the neural mechanisms by which you're going to be controlling respiration. We have multiple nervous centers that are going to be responsible to regulate the rate, depth, and pattern of breathing. Those are the pontine respiratory centers and my medullary respiratory centers. So pontine respiratory center is the one that's going to be responsible to smooth the respiratory pattern. So if you are breathing, you don't have this rough pattern of breathing. So you're not doing this. So it's smooth. Can you notice the difference here from the sound? Can you notice any difference between the two? So what makes it smooth is the pontine respiratory center. The ventral respiratory group in the medulla oblongata, those gonna be responsible to maintain the rhythm. It has the rhythm generators, which will be driving the respiration. So I have the rhythm of breathing, so I have a pattern that I'm following. What creates this pattern of breathing is going to be the ventral respiratory group. Dorsal respiratory group is going to be the one that integrates the peripheral sensory input and modifies the rhythm of the ventral respiratory group. So what this means, if you are, for example, contracting a muscle, so do you need to breathe deeper or shallower? Do you need to breathe faster or slower? If you are contracting your muscles, what do you think? When I contract the muscles, would I need more or less oxygen? What do you think? I need more oxygen. So muscle contraction logically will do what? When you contract your muscle, logically it's going to be enhancing the rate and depth of breathing. So how this takes place? So when your muscle contracts, you've got receptors detecting the contraction inside your muscles. And those receptors will be sending signals that tells your brain that you are performing a contraction right now. So you're going to need to breathe faster. So which one is going to be receiving, which nervous center in your brain is going to be responsible to detect this sensation that you are contracting your muscle is going to be the dorsal group of your middle. So the dorsal respiratory group located in my medulla on here, this is the one that's going to be receiving the signal input from my muscles, as an example. And its function is to send out accordingly either excitatory or inhibitory signals to the ventral respiratory group, also in the medulla oblongata. And those signals, they will be modified to maintain a smooth pattern of breathing by the pontine center. So again, we have three centers here in the brain stems that are regulating the breathing. So we've got the pontine center, we've got a ventral respiratory group, and the dorsal respiratory group, who receives the signal from the peripheral receptors, and according to which you're going to be either increasing the rate or reducing the rate of breathing, is going to be your dorsal respiratory group. And the function here of the dorsal respiratory group, again, is to regulate the pattern of breathing that is generated from my ventral respiratory group. So rather than having a pattern like this, if I'm contracting the muscle, the pattern should look like this now. What makes those waves so smooth is going to be the pontine center. So they don't look like this. All right, this is not everything that we know. This is just a general overview of the function. This is a general overview of the function of the respiratory centers in the brain. So normally, the respiratory rate is 12 to 15 breaths per minute. This is a normal respiratory rate. What's going to be determining the rate and the depth of breathing? The depth is going to be determined by how actively the respiratory centers going to be stimulating the respiratory muscles. What this means? This means that a stronger stimulus from the respiratory center, which is, let's say, my ventral respiratory group, stronger stimulation will be doing what to the muscle? Will increase the force of contraction. And as I increase the force of contraction, what am I doing to the respiratory muscle, to the breathing? I will be creating a deeper breath. I'm increasing the tension in the muscle. And again, what did increase the tension of the muscle is going to be the strength of the stimulus that was sent from my respiratory center to my respiratory muscles. This is what I mean by how actively am I stimulating the muscle. But what determines the rate of breathing is going to be for how long did you activate your inspiratory center. The longer that you're going to be activating the respiratory centers for longer time means more stimulations gonna be arising, and more stimulations, each of them gonna be resulting in a muscle contraction. So let's say here I did stimulate the respiratory center for 1 second. This is not, those are not accurate numbers, just to give you the idea. So if I did stimulate the respiratory center for 1 second, what's going to happen? Let's say I will be performing only one stimulus. I will create only one stimulus that will be sent to the respiratory muscle. And one stimulus is going to result in one contraction. So I've got one contraction in this second. What if I did stimulate or did activate the respiratory centers not for 1 second? I did activate it for 2 seconds. So per each second, you create one stimulus. So now you've created 2 stimuli that will be followed by 2 respiratory muscle contractions. So now, rather than only breathing in once, I breathe in twice. So what happened here, I did increase the number of breaths per minute. So the longer you activate the respiratory center, the faster the respiratory rate will be. The stronger you're gonna be forming a stimulus that arises from the respiratory center, the deeper the breath will be. So this is the difference between the respiratory rate and the respiratory depth. All right, any questions here? Is this clear? Is this clear? The difference between the depth and the rate. So what determines the rate of breathing, again, is for how long did you activate the respiratory center. What determines the depth of breathing is going to be how actively did I stimulate the respiratory center. All right, so what are factors here that will be affecting the rate and depth of breathing? First, we've got the chemical factors. This includes carbon dioxide, hydrogen ions or protons, and oxygen levels. Increased levels of carbon dioxide, this is what we call hypercapnia. Hypocapnia will be depressing the respiration. So if a person is going to be losing consciousness, you give him a bag, a paper bag, and you ask him to breathe in the bag. So what you're trying to do here, you're trying to increase the carbon dioxide levels. The carbon dioxide level in his blood. And as a result, you are enhancing his respiration. So having too much carbon dioxide in my blood will do what to the respiratory rate? Will increase the respiratory rate. If I have a drop in the carbon dioxide levels in my blood, this is going to result in low respiratory rate. So I'm not breathing. Arterial oxygen partial pressure only going to be playing a role in determining, in affecting the depth and rate of breathing if it goes below 60 millimeter mercury. Remember what was the oxygen partial pressure in the arterial blood from last class? Normal arterial oxygen partial pressure was around 100 millimeter mercury. So if I do have a drop all the way to 60 millimeter mercury, at this point, the oxygen going to be playing a major role here in increasing the rate and depth of breathing. But the main factor that will be regulating the rate and depth is not going to be the oxygen partial pressure drop, because I will wait until it drops to 60 millimeter mercury for me to increase the respiratory rate and depth. The main factor here that regulates the rate and depth of breathing is going to be the carbon dioxide levels. This is going to be my main factor. Also, decreased pH. If you remember, pH in your blood, pH of the blood was 7.4 plus or minus 0.05. This was my normal pH. Remember, if I have low pH, this means I have acidosis. If I have higher than normal pH, it's alkalosis. So remember, having acidosis means you are accumulating protons, because acids are proton donors. Compared to having alkalosis, you're accumulating proton acceptors. Remember, carbon dioxide in your blood, it's soluble. It's going to be soluble in the form of any idea? Any idea? When it dissociates here, is going to result in the formation of protons. Carbon dioxide, if you remember, when it's soluble in my blood, it's gonna be carbonic acid. It's gonna be an acid. So having too much acids in my blood, stimulates me to breathe faster. And as I breathe faster, I would be getting rid of this carbon dioxide. This will reduce the amount of acids in my blood. What if I have alkalosis? What alkalosis did to my respiratory rate? I am dropping the respiratory rate. So I would be breathing slower. So slower breathing means you're gonna be retaining the carbon dioxide. And if I'm retaining the carbon dioxide, what's gonna happen? It starts to become accumulated as an acid. So this increases the amount of acids in my system. So for Joe, so the rate is the change in breath per minute, and the depth is how much air you're taking in. Yes, exactly. So respiratory rate is going to be how many contractions do I perform, resulting in breathing in, out, in, out, in, out. So this is going to be the rate of breathing. But the depth of breathing is going to be determined by how strong you're going to be contracting the muscle. And the stronger you contract the respiratory muscles, what's going to happen? If you have more elevation of the ribs, more depression of the diaphragm, this means you're going to be increasing the volume of the chest. And as you increase the volume, you're going to be dropping the intrapleural pressure. And remember, the more you drop the intrapleural pressure, what happens to the transpulmonary pressure that keeps my lungs inflated? If it was 0 minus -4, now it becomes 0 minus -5. So what happens? It becomes 5 rather than 4. So it increases. And as you increase this transpulmonary pressure, what's going to happen to your lungs? Your lungs going to be increasing in size, allowing the air to flow in. So what if I did drop this pressure, the intrapleural pressure, because I did perform a stronger muscle contraction? If I dropped it to -6, I did create a stronger muscle contraction. I did have more depression of the diaphragm, more elevation of my ribs. So now the transpulmonary pressure, rather than being -5, it becomes, or the intrapleural pressure, rather than being -5, if I am getting the tidal volume in, it's going to be -6. So now the transpulmonary pressure is going to be 6. So rather than having a lung at the end of inspiration being this size, I will be increasing the volume of the lungs. And when I increase the volume of the lungs, what's going to happen to the amount of air that I can breathe in? You're going to be allowing more air to move into your lungs, because simply you did increase the lungs volume. So this allows you to breathe in more air. All right. Is this clear? Is the concept clear for everybody? So again, what is the main triggering factors that plays a role in regulating the rate of breathing? Is your carbon dioxide. Directly and indirectly by decreasing the blood pH. What else can affect the rate and depth other than the chemical factors, emotions, pain, body temperature changes and stressors, as well as the pulmonary irritants? So let's look on this diagram. So having low oxygen, having high carbon dioxide, having high protons in my blood, this will stimulate the peripheral chemoreceptors. And those chemoreceptors, again, will send the signals to which part of my brain? To mainly the dorsal respiratory group located in the medulla oblongata, stimulating the ventral respiratory group, increasing the rate of breathing. Also, I have central chemoreceptors in the brain itself, and those central chemoreceptors gonna be monitoring the amount of carbon dioxide, the amount of protons in the blood, and accordingly you're gonna be regulating the rate. So if I have an increase in the carbon dioxide levels, if I have an increase in my protons, this will stimulate my respiratory centers, making me breathing faster. Contraction of the muscles also will stimulate the respiratory centers. What inhibits the respiratory centers is going to be those are going to be the stretch receptors of the lungs. So if you decided to breathe in as much as you can, so you're going to have a limit at which you can't increase the depth beyond. So I can't get more air in my lungs beyond this range, simply because I did activate the stretch receptors in the lungs, which will be inhibiting the respiratory centers. Also irritants. So if you are breathing fumes, for example, you will see yourself stopping breathing. So I'm not gonna be willing to allow those fumes into my lungs. So if you're breathing lots of dust, for example, you're gonna feel, even if you didn't notice, you will, the irritation itself of the airways and the lung tissue will be inhibiting the respiratory center, preventing you from getting more of those fumes and more of those irritants into your lungs. For Kelly, when I'm monitoring anesthesia for my patients, I notice hypercapnia when they are not breathing as much as they should be. Then I notice hypocapnia when they are breathing more than they should be. What is the contradiction? That is that because I'm only measuring carbon dioxide on an anesthesia monitoring machine and not from the blood. So you're measuring here the anesthesia monitoring machine that tests what exactly? The air that the patient is breathing out. For Kelly, of what? Of the air they are breathing. So the difference here, so the breathing, this machine is simply doing what? So it's measuring the amount in the blood How? By simply measuring the amount of carbon dioxide that the patient is breathing in and subtracts the amount that the patient is breathing out. So it allows you to calculate the amount that is kept in the blood. All right, so having here hypocapnia when they are breathing more than they should be. So if I have faster breathing, I have fast respiratory rate. This means I will be washing out more carbon dioxide. So the carbon dioxide levels will start to drop in my blood, which is simply going to be figured out by the machine by checking the amount of carbon dioxide that you're breathing in, which is almost a zero, and check the amount that you're breathing out. So if I'm breathing out too much carbon dioxide, this simply means that the carbon dioxide levels in the blood are dropping. And if I have a drop in the respiratory rate for any other reason, so the respiratory rate is going down, so this means I will be accumulating carbon dioxide. So normally it should be correcting the respiratory rate. So what you are monitoring is the effect of the breathing on the carbon dioxide levels. You don't want to have hypocapnia because this is going to be inhibiting breathing. So if it goes too low, this is going to be inhibiting the respiration. So if the patient is going to be breathing faster than he should be, this is going to cause a drop in the carbon dioxide levels, which will result in a negative feedback. So dropping his respiratory rate might be below normal. So he won't be able to get the oxygen he needs. So the problem here with the carbon dioxide, if I have a drop in the carbon dioxide levels, what I'm trying to do, I'm trying to rebuild this carbon dioxide by inhibiting the respiration. This is my concern. But your concern as a healthcare provider is the oxygen levels. What's going to happen if you did inhibit respiration because you have a drop in the carbon dioxide levels? You're going to be reducing, not only increasing the carbon dioxide levels, which what the patient is trying to do, but this will also result in a drop in the amount of oxygen he will be getting. I'm not sure if this has answered your question or not. All right. Any questions? Any questions? Any questions concerning the rate and depth of breathing? All right, great. So hyperventilation increase is going to be defined by an increase in the depth and rate of breathing that exceeds the body needs to remove the carbon dioxide. So I'm removing the carbon dioxide faster than I should be. And as a result of the hypocapnia, what's going to happen? You're going to be inhibiting the many of the brain functions because this results in cerebral vasoconstriction and will result in cerebral ischemia. So hypocapnia here, why is it not good to have low carbon dioxide levels? Because this will directly result in cerebral ischemia. Having very small amounts of carbon dioxide in the blood gonna result in a constriction of the cerebral vessels. Constriction of the cerebral vessels. Apnea, and the reverse, of course. So if I have too much carbon dioxide, my blood vessels will dilate in the brain. So did you notice before when you are, for example, sitting around a fire pit, or you have a barbecue and you are on the grill, did you ever notice that you develop headaches? So when you are sitting around a fire pit or on a grill in a barbecue, you're grilling. So headache, why? Because simply you are breathing out in lots of carbon dioxide. And when I breathe in carbon dioxide, the carbon dioxide levels in my blood will increase. And when I increase the carbon dioxide levels, this will dilate the cerebral vessels. And once the blood vessels in the meninges and the brain are going to be dilated, this is what causes the stretch of the meningeal coverings and results in developing of headaches. So that's why a person will develop headache if he gets exposed to lots of carbon dioxide. On the other hand, if I have low carbon dioxide levels because the patient is breathing faster than normal, this will cause constriction of the cerebral vessels and can result in cerebral ischemia. Apnea is a period of breathing cessation. So I stop breathing for a brief period of time. This will be taking place if the partial pressure of the carbon dioxide levels are abnormally low. So if I have low carbon dioxide levels, remember, this will be inhibiting the respiration. So I will stop breathing for a brief period of time. This is called apnea. All right. What is going to happen to the carbon dioxide levels, do you think, and the oxygen levels in your arterial blood when you are exercising? So if you are running a sprint now, and we measured the arterial gases, the amount of carbon dioxide, the amount of oxygen in your blood, what do you think is going to be the amount of oxygen, the amount of carbon dioxide? Will the amount of oxygen drop, stays the same, or increase? Those three choices on here. So we have three choices. What do you think can happen to the oxygen levels? Would they drop, stay the same, or would they increase? Increase, 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 increase. The demand for the oxygen increases. So when I contract, when I exercise, so my muscles are going to be consuming more or less oxygen. My muscles, would they consume more or less oxygen? They will consume more oxygen, right? And if I'm consuming more oxygen because I'm contracting my skeletal muscles, what's going to happen to the oxygen levels in my blood if I'm consuming more of the oxygen? if I'm consuming more oxygen by the muscles, what's going to happen to the oxygen levels in your blood? Decrease, decrease, decrease. So it's going to stay the same. It's going to stay the same. It's going to remain surprisingly constant. Why? Because in the same time, once you contract your muscles, what happens to your respiratory rate? It's going to increase immediately. You don't wait until you have a drop in the oxygen levels to activate your respiratory centers. Once you contract a muscle, the muscle contraction itself is going to be increasing the respiratory rate. The ventilation can go 10, 20-fold in response to the metabolic needs. You don't have to drop the oxygen levels. You don't have to increase the carbon dioxide levels when you exercise in order for you to increase the respiratory rate. Respiratory rate will be increased once you contract your muscles. So during exercise, again, what's going to happen to the carbon dioxide levels? What's going to happen to the oxygen level? What's going to happen to the pH of the blood? What do you think? They will remain constant. They will remain constant. All right, this is a very common true and false questions that you might see on the test. Because most of the people will think either they think of only one aspect at a time. So they only think, so when I exercise, I'm breathing faster, so my respiratory rate gonna increase, so my oxygen levels. Or they think only of the other aspect. I have muscles that are consuming oxygen when I exercise, so the oxygen levels will be dropping. But actually, both of them are gonna be taking place in the same exact time, keeping my oxygen level constant. Clear, clear? All right, so moving on to the respiratory adjustments. So remember, you are here, and above you, you've got pressure. And remember, what do we call the pressure that is applied on our bodies? This is called the atmospheric pressure. This is my atmospheric pressure. What's gonna happen if I decided to travel up on a mountain? What's gonna happen to the atmospheric pressure now applied on me? Remember, the pressure is applied by the gases, and if you are traveling on a mountain, what's going to happen to the amount of gases above your head right now? You're going to have less gases. This means you're going to have lower atmospheric pressure. Low atmospheric pressure. So having low atmospheric pressure, how is this going to affect me? Remember, in order for me to breathe normally, here. Lungs pressure is equal to the atmospheric pressure. So if I have a sudden drop in the atmospheric pressure, I did travel to a high altitude. I did travel 8,000 feet quickly above sea level. So what's gonna happen if I have a sudden drop in my atmospheric pressure? The air won't be able to travel into my lungs. This is one thing. Because here I did have a zero atmospheric pressure, or a zero pressure equal to the normal atmospheric pressure. So whenever I have a drop in the sudden drop in the atmospheric pressure around me, what's going to happen? I will fail to get the air from outside into my lungs. If it was sudden, if it was gradual, if you are actually climbing over days, this will allow the lungs to adjust to the new atmospheric pressure. So if I have, again, a sudden drop in the atmospheric pressure, like by traveling quickly 8,000 feet above sea level, this can cause what we call the acute mountain sickness. Acute mountain sickness is going to be manifested by having headaches. So I have headache, shortness of breath. Why? Because I'm trying to exert more effort to pull the air. So remember, what creates the difference between the pressure in my lungs and the atmosphere? Normally, they are for most of the times they are equal. Both sides gonna have a zero pressure. Both sides are equal. So if I'm dropping the pressure outside, what I will be trying to do, I will be trying to perform stronger contraction of my respiratory muscles. Why? To create a lower or a lower pressure in my lungs compared to the atmosphere. So if I'm normally creating -1 millimeter mercury, and I had a drop of 5 outsides in the atmospheric pressure, so I should be dropping 6 millimeter mercury instead of 1 to keep the same difference. So if the difference between the atmospheric pressure, if you remember, atmospheric pressure was a zero pressure, and in the lungs, when you contract your diaphragm, you elevate your ribs, this will be dropping the pulmonary pressure to -1. So the difference between the two that allows the air in was equal to 1 millimeter mercury. This is the difference between inside and outside. This is the driving force that allows the air to flow in during inspiration. So let's say this pressure did drop because I did travel up on a mountain rapidly. So what's going to happen? Let's say I have a drop of 5 or 3 millimeter mercury. To keep the difference the same, to allow the same amount of air in here, rather than creating a negative pressure of 1 millimeter mercury, I need to drop it to 4 millimeter mercury. So I need to perform stronger contraction of my respiratory muscles, and this allows me to create a more negative pressure inside the lungs to allow the air in. So what's going to be the manifestation on here? in terms of breathing, I have shortness of breath. I'm trying to breathe deeper, and this will definitely slow down the respiratory rate. Also, as you are releasing, you are reducing the atmospheric pressure. This atmospheric pressure is not only applied on your respiratory system, it's also going to be applied on every part or on every body organ. So one of the organs that will be affected is going to be the gastrointestinal tract. And remember, the gastrointestinal tract is lined by a mucosal lining, which is going to be releasing the mucus on here of the gastrointestinal tract. So when you are reducing the pressure on those cells, which is the atmospheric pressure, what's going to happen? I will start to leak more fluid in here. And the more fluid I leak in here, this causes nausea. Also, I have a drop in the atmospheric pressure on the blood vessels. So I don't have enough pressure applied on the vessel. So the vessels are gonna be leaking more fluid outside in between my cells. This can cause cerebral edema, so I'm leaking fluid in between my brain cells. It can cause pulmonary edema. I'm leaking fluid in my air sacs, and both of them can be lethal. So both of them can cause death. So again, what we're discussing now is the acute mountain sickness is gonna take place if a person travels rapidly 8,000 feet above sea levels. This is going to cause a major drop in the atmospheric pressure. It's going to be manifested by headache, shortness of breath, and nausea, as well as cerebral, and in some cases, pulmonary edema, cerebral and pulmonary edema, which are lethal. Questions? So now, how quickly? I'm not exactly sure of the timing. I will look this up and I will tell you after break, Melissa. I'm not sure of the timing, but I believe it's going to be slightly different. I will give you a range after break. I will check it out. I need to double check. I need to double check exactly the time frame for the adjustment to take place normally. All right, Martina Hayes said that she have seen it in hours to a day. So I will double check it and will give you hopefully a definitive answer. All right, so we're looking here at what happens if a person now is diving. So you're diving now. So can I just grab a bag of air, a plastic bag, fill it with air, and breathe it underwater? Would this be a good idea? Why not? Why not? I need compressed air. Why do I need compressed air? Remember, at sea level, what is the pressure applied on you at sea level if you are still at sea level here? The pressure applied on you is the atmospheric pressure, right? But when you are diving, you're not only adding gases on top of you, you're adding liquid, you're adding water. So every 33 feet you're moving down, this adds one whole atmospheric pressure, one atmosphere. So if I did travel just 33 feet below underwater, I have 2 atmosphere applied on me, double the atmospheric pressure. So outside I have the pressure applied on my chest like this. This is my chest. Atmospheric pressure is gonna be compressing my chest. Why my chest doesn't collapse? Because remember, your lungs gonna have the same pressure like the atmosphere at the sea level because it's connected to the atmosphere. Remember, the lungs are connected to the atmosphere, so air can flow in and out freely to equalize the pressure on both sides. So outside I have atmospheric pressure, inside I have an atmospheric pressure. What if I'm diving? If I'm diving, I'm adding only atmospheric pressure. So let's say I did travel down 66 feet under sea level. So what's gonna happen underwater? So now the atmospheric pressure is 3 times the normal atmospheric pressure. So it's 3 atmosphere. Inside my lungs, I still have the sea level atmospheric pressure, which is gonna be 1 atmosphere. So what's gonna happen? Outside you have much greater pressure than inside. So as a result, what's gonna happen to your chest? The chest is gonna be collapsed. This is gonna be compressing and collapsing the chest. All right. So in order for me to equalize the pressure on both sides, what should I be doing? I should be breathing compressed air. So I have a monitor here that will be checking the atmospheric pressure, and accordingly, it's gonna be allowing air to travel into my lungs at the same pressure as the surrounding pressure. So if outside was 3 atmosphere, so the air that is gonna be traveling into my lungs should be also 3 atmosphere. And this is gonna be regulated by the monitor of the pressures that you see. I'm not sure of the name of this monitor. Anybody has an idea what is the name of the pressure monitor that is attached to the air cylinder? You know what I'm talking about? You know what I'm talking about? Yeah. pressure, barometer. All right, so did you get my idea? Did you get what I'm talking about here? This is the one that will be regulating the pressure of air that's going to be traveling to the person who's diving. And again, what is the importance on here is to keep the pressure inside the lungs equal to the pressure outside for my chest to not collapse. So what does it mean for me that I have compressed air? It's air at higher pressure, right? Or in other words, more air. So let's say here, this is the amount of air. In this cup. What does it mean to have compressed air? This simply means you did increase the amount of air, the volume of the air, and you kept it in this at the same volume. Remember, gases, they don't have neither a definitive shape or a definitive volume. They have a volume determined according to the pressure. So if I have a cup, empty cup, this means it's filled by air at an atmospheric pressure of 760 millimeter mercury. That's it. So this cup is filled by air, and the volume of the air is the volume of the cup, and the pressure it's 760. What does it mean to have a compressed air? This simply means that rather than, let's say, this cup I did start with can hold all this can, right? This is a bottle, can. It has 1 liter of air at a pressure of 760 millimeter mercury. All right. If I have the same can on here, but rather than adding, I have only 1 liter, I will be adding 2 liter of air in the same can. So rather than having 1 liter, I have 2 liters. So this means what? This means in terms of volume, I still gonna have the same volume. The volume of the can is 1 liter. But what happens to the pressure? The pressure here, as you did double the volume, but you kept it in a smaller container, so you're gonna have double the pressure. Does this make sense? So again, what I mean by compressed air is simply more air in the same container. Once you've got more air in the same container, this is going to result in what again? This is going to result in an increase in its pressure. All right. So what might be a problem here if I'm diving? I'm diving. and all of a sudden you have seen a shark. All right, it should be. So what you're gonna do is reflex. Yeah, this is, if you are an expert, you move towards the shark. All right. You just don't panic. All right, so, but if a person is not an expert, he didn't dive before, this is his first time, and he didn't get appropriate training, or for whatever emergency other than a shark, what you're gonna do, what a person might do, he will rapidly ascend. He goes up. He goes up rapidly. So what is the pressure of air that I was breathing? If you remember, it was 3 atmosphere. 3 atmosphere. And outside of my chest, I did have a pressure of also 3 atmosphere. So I didn't have a problem. So no chest compression. My chest will not collapse because the pressure inside is the same as outside. So I have no problem. The problem here, if I did drop this pressure, because I rapidly ascend, I did go up rapidly, what's gonna happen? If this pressure did drop all of a sudden to 2 atmosphere or 1 atmosphere, the pressure applied on the air inside the lung has been reduced suddenly. So what's gonna happen to the amount of air? What's gonna happen to the volume of the air inside? Let's say I have 1 liter, it's the same liter of air at 3 atmospheres. So this is my pressure. If I dropped this pressure to 1 atmosphere, what's gonna happen to the volume now? It won't remain as 1 liter, it's gonna be 3 liters. Yeah, you should. So for the discussion on the shark, if you see in a shark, you either stay still, do not panic, or if you are in a group, try to move slowly towards the shark, just as a group, to give it an impression that you're good, like you're not afraid, so it won't attack you. All right, so again here, what happens if I did have a drop? If I don't have a sudden drop of the pressure, air inside is, let's say, 1 liter. Air at 3 atmosphere. This is the pressure inside the lungs. Outside I have 3 atmosphere, so no problem. If I rapidly ascend, what happens to the pressure applied on my chest? I'm going up. On here, I'm going up. So the amount of water above me is going to be reduced. So what happens to the surrounding pressure? So if here I was at 3 atmosphere, when I go up, this will drop to 2 atmosphere, let's say. or 1 atmosphere. In my lungs, I did have 1 liter at 3 atmosphere. 1 liter at 3 atmosphere, when you drop the pressure here, when I drop this gas pressure, what's going to happen to the volume of the air? Increases. And remember, air sacs are formed of 1 row of flattened cells. So if you decided to double, let's say, or triple the amount of air in those air sacs, would they be able to tolerate this increase in the air volume? So air, why the air is going to be increasing its volume? Because of the drop in the pressure. All right. So if we're looking here, if we're looking here, at the amount of air inside, it's going to be doubling, or it's going to be 3 times the amount of air that you should have in the lungs. So what's going to happen? This is going to cause an overinflation of the air sacs and results in a barotrauma or rupture of the alveoli. Also, what keeps the gases in a soluble form in your blood. So in your blood, you've got lots of nitrogen, which is normally soluble at a normal pressure. So if you rapidly ascend, you are reducing the pressure applied on the gases that keep them soluble. So the nitrogen, rather than being in its soluble form, it's gonna become a gas and will start to form gas bubbles within the blood that might result in a formation of an embolus and might block one of the cerebral vessels, causing a stroke formation. That's why a person on a rapid ascent might develop a paralysis. Most likely it's going to be hemiplegia. All right. Moving on to homeostatic imbalances, but let's have a break for 10 before we move on to the homeostatic imbalances. Again, after break, we're going to be reviewing the diagrams, which are important for us for the upcoming lab exam. Again, I will be in contact with the college. Another time, I will double check when the smarter proctoring will be live. I know that they did reach an agreement and they will be conducting live online proctoring, but I'm not sure when it will become available for us to use. All right, I still can't see it on campus, so I will double check with them and I will be updating you with the exam due date accordingly. But after break, we're gonna be reviewing the important diagrams that we will be covering for the upcoming lab exam. All right. Any questions before we go to the break? All right, we'll see you in 10. Yeah, the files section, it was removed from Canvas because this is the source of the diagrams that will be available for you on the test. So I don't want to make them available before the test. So the only way that you can only see the diagrams that I will be using on the actual test and to not allow you to to have access to them before the exam is by hiding the files folder. All right, but what files do you need? All the files should be under the 4 modules. So for example, the lecture slides on here are under the Unit 3 module. Next chapter is going to be under Unit 4 module. The lecture PowerPoints, the lab PowerPoints are also under the modules. I will double check if all the modules are going to be, or if all the files are posted under the modules, and if any of them is missing, I will be posting it on the home page. But the files section is going to be hidden for you to not have access to the diagrams I'm using for the quiz. And this what was the problem for some of you on the previous exam. On the previous exam, what I did, I tried to hide the folder inside the files section that contains the diagrams, which caused the diagrams to disappear from the actual test. So this was the only solution for me to give you diagrams on an exam through Canvas and for you to not access them. All right, we'll see you in 10. All right, welcome back. For those who were asking about the time frame for the acute mountain sickness, see here that it states that it develops, the person develops symptoms after ascent between 8 to 36 hours. But I don't see like a clear time frame for how fast you would be going in order to develop these symptoms. So I believe it's going to be different from one person to another. It's more of a diagnosis. So a person will develop it, generally speaking, if he doesn't have rest and he did climb to this attitude at a fast rate. But how fast is it to develop the symptoms is going to be variable from one person to another. This is what I believe. But the symptoms going to be developed between between 8 to 36 hours after ascent. All right, if you could find like a time frame that uh, that will be uh, telling you exactly how fast you should be going in order to develop the acute mountain sickness, please let me know. But from my review on here on the internet, I couldn't find a suitable answer to address the question. All right. If you did find an answer to the question, please let me know. All right. So we're looking here at the chronic obstructive lung disease or pulmonary disease or COPD. COPD is actually two problems in one patient. So I have chronic bronchitis and emphysema. Those two together will develop COPD. Most of the COPD patients are going to be smokers. If a person is smoking cigarettes, he constantly going to be irritating his airways. And for those who are smoking, just to get an impression about how the smoke is acting as an irritant, try to imagine that this smoke passes into your gastrointestinal tract. So it happens in some cases, rather than inhaling the smoke into your airways, some of it passes to your gastrointestinal tract. You will see that it causes a lot of irritation to your esophagus, a lot of irritation to your stomach. But you don't feel the same irritation in here in the airways simply because it's lined with mucus. So it reduces the irritation, but it's still an irritant, a major irritant to the airways. And how your body responds usually to an irritation Any irritation, your body responds by developing inflammation. And remember, inflammation in one word is, you remember, back from the immunity? Summarize all the effects. Inflammation is exactly vasodilation. You dilate the vessels. You dilate the vessels. So if I'm dilating the vessels in the airways, what's going to happen if I'm focusing on this bronchi on here? I'm dilating the vessels associated with the bronchi, so the bronchi will start to accumulate more and more mucus. The cilia of the epithelium are going to be inhibited, and person will start to accumulate lots of mucus. What happens to the diameter available for the air to travel through? On here. So I have a much smaller diameter now of the bronchi. Because of the chronic irritation, I develop chronic inflammation. And as a result of the inflammation, I am narrowing the diameter of the bronchi, of the airways. I am accumulating lots of mucus in here. I'm inhibiting the propulsion of the cilia of the epithelium that allows me to clear the airways. So this would be the chronic bronchitis part. So I have bronchial edema. The patient here will be trying to get rid of this mucus, but it's too thick for the epithelium to move by the propulsion effect of the cilia. So what he will be trying to do, he will be trying to increase the pressure on the airways by coughing, and this increased pressure and forced air is going to be trying to dislodge the mucus from the bronchi. So that's why one of the major characteristics on here that we see with chronic bronchitis would be productive cough. Patient would be producing mucus, lots of mucus by the effect of the inflammation, and he's not going to be able to move this mucus from his airways just by the propulsion effect of the cilia of the epithelium. So as it accumulates, it's going to be narrowing the diameter of the bronchi and will result in productive cough. Also, the irritation will cause the bronchi to contract. So I will develop bronchospasm. So I'm not only reducing the diameter of the bronchi by accumulating mucus inside, I'm also contracting the smooth muscles in the bronchi, causing bronchospasm. So I'm exerting more effort to move the air in. So in order for me to move the air in, I need the air to travel at a greater pressure. I need higher pressure for me to overcome the obstruction in my bronchi, because the bronchi are smaller in diameter now because of the bronchospasm, again, and the accumulation of the mucus. So how would I be able to overcome the obstruction and get air to travel in? The patient here is going to be pursing his lips. Reducing the diameter on here will create high resistance against the flow of air, and as a result, increases the pressure of the airflow. Another thing that the patient will be doing is going to be to perform stronger contractions of his respiratory muscles. So he's going to be trying to breathe deeper in order to create a more negative pressure inside his lungs to pull the air in at a higher pressure in order for him to overcome the obstruction of the airways. So patients here will have air hunger, shortness of breath. Another problem that I have in here, so I've overcome the obstruction by increasing the force of airflow through those constricted bronchi. I'm still going to be able to overcome this obstruction by increasing the pressure of the air. But the problem here is when I move the air back out, it's going to be much more difficult for me to get this air out of my lungs. So air going to be trapped in the lung. And we're going to see another problem that the patient will have, also going to be increasing the trapped air. All right, so again, what is the problem here? Problem is I have chronic irritation of the bronchi, and this chronic irritation will result in chronic inflammation. I have edema, I have mucus secretion from the mucosa lining of the bronchi. Also, I have bronchospasm. My bronchi are contracted. This increases the airway resistance, and this what will cause the air hunger. The patient is going to be pursing his lips to create more resistance against the airflow, which increases its pressure. He's going to be contracting his respiratory muscles, more forcefully to increase the negative pressure within his lungs to allow the air to travel through the obstructed airways. Can exposure to chemicals for a long time in a work area also cause, or not just smoking? Yes, definitely. But some of the chemicals, not all chemicals can cause COPD. Some of the chemicals can cause fibrosis of the lung tissue. Some chemicals might cause lung cancer. So the patient will develop lung cancer before even getting COPD. So it's going to be variable according to what chemical he's breathing. All right, so not COPD doesn't develop with every single chemical. All right, but the most common reason is going to be smoking. Joanna, if you stop smoking, will the inflammation decrease? Yes, inflammation decreases. Inflammation decreases. But the alteration in the structure of the lung will not. The structure itself of the lung, as we're going to see in a minute, the size of the lung is still going to be larger in size, as we're going to see in a second. But the bronchial inflammation, yes, it will resolve over time. Martina, I don't understand high pressure oxygen. What was it, a response to a question I was saying? All right, great. So again, first thing that is going to be first component of COPD is having chronic bronchitis. And again, this is caused by the effect of the chronic inflammation. Another thing that gets developed due to smoking is the emphysema part. And emphysema is simply a loss of the elasticity of the lung. Loss of elasticity of the lung. So try, for example, on here, so if you have elastic compressive pants, for example, or shorts that you are using, if you kept using it over and over for years, will it be performing the same degree of compression as when you get it brand new short? You know those sport shorts that will be compressing the muscles? Yeah, over time, what's going to happen? They are not going to be, they lose their elasticity. They won't be recoiling as a new one. They won't be compressing your muscles as a new one anymore. This is exactly what emphysema is. I've lost the elasticity of the lung. Normally you shouldn't. Because unlike those shorts, your lungs can rebuild the elastic tissue. But because of an increase in the destruction rate that exceeds the ability of the lung to regenerate the elastic tissue, this will reduce the ability of the lung to recoil. This can be an effect of smoking. Smoking breaks down the elastic tissue. Also, there is a genetic disease. This is alpha-1 antitrypsin deficiency. Is gonna also result in over destruction of the elastic tissue. And if I am reducing the elastic tissue in the lungs will fail to recoil. And what's gonna happen if the lungs fail to recoil? Rather than being able to squeeze out the air outside of my air sacs, if I had a reduction in my elasticity, the air will not be moving out. It's going to be trapped. Remember, what worsens the condition on here is that those patients also gonna have chronic bronchitis. So I have narrow bronchi, narrow airways, and I have lost my ability to squeeze the air out. So the air gonna remain in my lungs. Remember, the person here was pursing his lips. He was performing a forceful inspiration to get the air at a high pressure to overcome the obstruction. Now, I'm not only trying to overcome the obstruction, I am also trying to overcome the pressure within my air sacs, because in the air sacs, I have got air trapped in here. So I'm not only trying to overcome the obstruction in the airways, I'm also trying to create a pressure greater than the pressure inside my air sacs. So what happens over time? You're getting air from outside. Some of this air gets trapped. You're getting more air from outside. Some of it gets trapped. So what happens over time to the size of the lungs? What do you think? Inflates. Size of the lungs is going to be increased. Increases. Any other ideas? So what's going to happen to the chest if I did have an increase in the size of the lungs? I will develop barrel chest, exactly. So if we're looking on here, this is going to be a normal chest. If you notice on here, the anteroposterior diameter of the chest is much smaller than the transverse diameter. Over time, as I expand the lungs, the anteroposterior diameter is going to be increased. So the chest now looks like a barrel. We call this is barrel chest. Right, look in here, barrel chest. All right, so again, what caused what results in the formation of the barrel chest is simply you have air trapped over years in your lungs, and as I fail to move this air out because I've lost the elasticity of the lung due to over destruction of the elastic tissue, I did have an increase in the breakdown of the elastic tissue. This results in more air trapping in the lungs, and what worsens the air trapping is that you actually have narrow bronchi caused by the chronic bronchitis associated with the COPD. So over time, what happens to those patients? They have air trapping. They will have difficulty breathing. They will develop dyspnea. As I have accumulation of mucus in my airways, I have stagnation of the air. I have air trapped in my lungs. I'm not moving this air in and out. So all those together, both of them together, gonna cause stagnation. And if you don't have movement of the air, if you don't have movement of the mucus, this creates a favorable medium for the bacteria to grow, causing recurrent infections. And recurrent infections can actually cause fibrosis over time. Yes, if a person has only emphysema without chronic bronchitis, he might develop barrel chest as well, Melissa. Because think of it, you've got air trapped in, increasing the size of the lung, but you're still gonna have the stagnation, air gonna be trapped. So over time, person also develops some kind of inflammation of the airways due to the infections. So if I started by having just emphysema, it also can cause infections and will result in inflammation of the airways. But the main thing that causes the barrel chest development is the air trapping in the lungs, which will actually increase the size of the lungs. If I have air trapping, this will definitely reduce my ability to ventilate. So air is trapped inside. I'm not changing this amount of air in here. I'm only able to change this amount of air. So I have a reduction in the ventilation, which results in hypoxemia. I have low oxygen in my blood and hypoventilation because I'm trying to breathe deeper. So I'm trying to reduce. As a result, I will have a reduction in the respiratory rate. So you see on here, have 12 to 15. If I'm breathing deeper to overcome the obstruction, it takes me longer to breathe in. So if it takes me longer, I have less breath per minute. So this can cause hypoventilation. So again, COPD, it's a combined chronic bronchitis and emphysema. There will be an irreversible decrease in the ability to force air out of the lungs. So air gets trapped in. I will have breakdown of the elastic tissue in the lungs. This is an irreversible damage. The reversible part, if a person stops smoking, is that he will not be getting those recurrent infections. He will not be producing productive cough. He will be able to reduce the chronic bronchitis. But the damage here to the lung parenchyma is going to be an irreversible damage. 80% of the patients with COPD have history of smoking. Patients will have air hunger. They are breathing deeper, and as I'm breathing deeper, I would be breathing slower than normal, so I have hypoventilation. Coughing and productive cough, and the patients here will develop recurrent pulmonary infections. Yes, so patients will, if they develop bronchitis and acute exacerbation of the bronchitis, due to an infection that happened. So a person develops a pulmonary infection and it gets worse, so they will definitely give him antibiotics. But like a resolution for the chronic bronchitis, it won't be effective if the person kept smoking. So I can reduce the inflammation by giving him inhaler, like antihistaminics in an inhaler, for example. This is going to reduce the bronchitis, but it will not resolve it on the long run if he's still smoking. Asthma is characterized by coughing, dyspnea, wheezing, and chest tightness. So asthma is an active inflammation of the airways. It got the bronchitis part of the COPD. And an inflamed airways gonna also be contracting in response to the inflammation. So I've got bronchi which are contracted, bronchospasm, and they start to accumulate mucus inside, same as what we've just seen in the bronchitis of the COPD. What triggered the active inflammation on here is the release of IgE interleukins that will be recruiting a large number of inflammatory cells. This is a hypersensitivity reaction. I am breathing dust particles which are harmless. This causes an exaggerated immunological response, causing the release of inflammatory mediators, trying to recruit more inflammatory cells and activate them. And the more cells that get recruited, the stronger the inflammation that I will get, and it's going to be much more difficult to breathe. So how do I treat asthma, or how do I resolve an acute asthmatic attack? I will be given inflammatory inhibitors to the patient by an inhaler. I'm trying to reduce interleukins. I'm trying to reduce one of the most potent inflammatory mediators, which is the histamine. All right, but there is no definitive treatment. So there is no single medication that you can take and get it resolved for life. It's not like an infection. Taking an antibiotic for you to get rid of the infection. This is something that you're going to be managing, not resolving. All right, any questions on here for the asthma? All right, so moving on to an infection related to the respiratory system. This is going to be the tuberculosis, which is mediated by a bacteria called Mycobacterium tuberculosis. TB has very characteristic symptoms: fever, night sweats, weight loss. Those are the alarming symptoms. If you remember, we've seen those symptoms with two other diseases. Can you remind me, what are the symptoms? What are the two other diseases that we've discussed that did manifest by alarming symptoms: night sweats, fever, and weight loss? HIV, AIDS. What else? HIV, AIDS, and acute leukemia. Acute leukemia. Treatment is so hard. In order to treat patient with TB, he needs a course of 3 different antibiotics to be given for 12-month period. It's gonna be a very tough type of bacteria to get rid of. Lung cancers, this is gonna be the leading cause of cancer death in North America. 90% of all cases are resulting from smoking. We have 3 major types. The most common type is gonna be developing from the bronchial epithelium. This is my squamous cell carcinoma. Comes after that is going to be the adenocarcinoma, which is going to be developed from the peripheral lung areas. Small cell carcinoma, it's a lymphocytic-like cell that originate in the primary bronchi, and it has a very high metastatic ability. It metastasizes very rapidly. So can you remind me what kind of epithelium do I have in my bronchi? What kind of epithelial lining do I have? Bronchioles, bronchi. Type 1 cells, type 1 alveolar cells, those are cells of the air sacs. If you remember, alveolus did have type 1 alveolar cells and type 2 alveolar cells. Those are epithelial cells lining the air sacs, which are, but what is the type of epithelium? It's simple squamous, right? Simple squamous epithelium of the air sacs. My question now is, what is the type of epithelium lining the bronchi and the bronchioles? Celiac, cuboidal squamous, pseudostratified, ciliated, simple squamous, squamous cells. Remember, how do we classify the epithelium? We classify according to number of cell layers, either simple or stratified. And according to the shape of the apical cells, either squamous, cuboidal, or columnar. So simple squamous is the type of epithelium lining my air sacs, alveolus. This is the type of epithelium that I have lining my bronchi. It's simple columnar epithelium, which is ciliated. Ciliated, simple columnar epithelium. Which one was a pseudostratified columnar ciliated epithelium? This was the trachea. Pseudostratified columnar ciliated epithelium was in the trachea. So here I have simple columnar epithelium. So how can I develop squamous cell carcinoma? In the bronchial epithelium, if I don't have squamous cells, how would I get a cancerous squamous cell? in a site where I don't have squamous cells? What do you think? So it's coming from another tissue. Remember, epithelium doesn't travel anywhere. Epithelium is avascular. And it's originating, what I'm saying here, it's originating from the bronchial epithelium. It's originating from the bronchial epithelium. So how can I develop a cancer of a cell that doesn't exist in this location? Recurring infections, you don't have to get recurrent infections in order to develop squamous cell carcinoma. What do you think? Mutation in the cell growth. Here I have what? Traveling. Smoke, which is an irritant, causes irritation of the epithelium. So how your epithelial lining is gonna be responding to irritation? If you are wearing a tight shoe and you kept running, what's gonna happen to the skin of your foot? It's gonna be swelling, it's gonna be inflamed, and over time it's gonna be thicker. Will it be thicker over time? Yes. So what happened on here? In response to the irritation, the epithelium is gonna be increasing the number of layers to reduce the amount of irritation it gets exposed to. And remember, epithelium was avascular, so it gets its nutrients from the underlying connective tissue. So if I kept dividing those cells and the cells are traveling up, older cells are traveling up, what happens as they move away from the basement membrane, they get less nutrients, so they will become squamous epithelium. This is the dysplasia. So I did change the type of epithelium in response to the irritation, chronic irritation. I kept smoking for years, irritating my epithelium. So the inflamed epithelium is gonna start to proliferate, and as the old cells are traveling up, they will become squamous cells. So now, did this person stop smoking? No, he did not. So now, which cells are exposed to the irritation now? The squamous cells. So now, those squamous cells are the ones that will turn malignant, developing again what kind of lung cancer? Squamous cell carcinoma. Make sense? Make sense? Adenocarcinoma. Remember, adeno is referring to a gland. And remember, what kind of epithelium is forming glands? Is columnar epithelium. Columnar cells are the ones that are building up glands. So the second type of lung cancer that we are looking at is adenocarcinoma. Adenocarcinoma, I'm related to adeno gland. In other words, I'm related to columnar cells. Do I have columnar cells in the peripheral lung areas, in my air sacs? What kind of epithelium do I have in here? Again, in my air sacs? simple squamous epithelium. But again, because of the irritation, those squamous cells can't tolerate this amount of irritation. So what will I have? I will have inflammation. Blood vessels are getting more blood delivered to those cells by the effect of inflammation. Those cells are gonna be responding to the inflammation by growing in size. So now the squamous cells will be turning columnar. Did this person stop smoking? No. So what cells are actually now exposed after they did respond to the irritation for years? They will become columnar. They are still getting exposed to the irritation. At this point, they will turn malignant, creating an adenocarcinoma. Make sense? Make sense? So again, you first respond to the irritation by trying to adapt to the irritant. And then if you couldn't adapt to the irritation, at this point only, the cells will become mad and will start to turn malignant. So usually I have a precancerous lesion that can be detected. So that's why a physician might ask a person to get a bronchoscope done. So I'm passing with the endoscope inside the airways to check if there is any precancerous lesion. Moving on to another homeostatic imbalance, and the last topic today is going to be my cystic fibrosis. Cystic fibrosis is a genetic disease. It's one of the most common lethal genetic diseases in North America. It's going to be 1 each 2,000 births. I have a faulty gene, CFTR gene, cystic fibrosis gene is faulty on here. The problem here is with the creation of the mucus. So now the mucus that gets released from my epithelium is thicker. It's more viscous. So what is the problem? The problem is that those epithelial cells with this area will not be able to move this thick mucus. And if I fail to move this thick mucus, this mucus remains for longer in my airways. And who loves stasis? If I have stasis, bacteria. So the bacteria will find this mucus a favorable medium for it to replicate, to grow. And this is gonna worsen the condition, developing recurrent pulmonary infections. And over years, as I keep getting infection after infection, how your body responds to an infection, it responds to the infections by inducing inflammation. And inflammation gets resolved by what? By formation of scar tissue. So over years, what's going to happen to the lungs? The lung parenchyma gets replaced by scar tissue, resulting in lung fibrosis. And this is going to be the most common cause of death in those patients. How do we manage? We try to give vaccines, all possible vaccines of the bacteria that can cause pulmonary infections. Many genetic therapy are still under development and under research. All right. This is one aspect of the cystic fibrosis. Another aspect of cystic fibrosis is having the digestive problems, because you're not only producing mucus within the airways, you're also going to be producing mucus within the gastrointestinal tract. So thicker mucus in the gastrointestinal tract also going to have a lot of enteric complications. All right, we'll go for another break for 3 minutes, and we're going to be reviewing now the diagrams which we will be covering for the upcoming lab exam. It's an induced, the same concept on here, but it's much more aggressive. For COVID-19 is going to be the same concept. I'm inducing inflammation, and as I induce the inflammation, the lungs heals by fibrosis. So if you look at an X-ray of a person who has COVID-19, you'll see lots of fibrosis. Those white markings are the accumulated fibrous tissue on here. All right, Francesca, for the lab exam, the date hasn't been determined yet. I'm still waiting for me to see whether they will be opening the proctoring platform anytime soon or not. All right. Right, so we'll go for a break for 2 minutes or 3 minutes. We will be back for the diagrams review. All right, so let's start first with the diagrams. So for the scar tissue, Melissa, scar tissue going to remain, but it's going to be shrinking. So it's going to be reduced in size. So all the time you're going to have some degree of breakdown, but it will not fully resolve back to normal. All right. So over time, the breakdown of this scar tissue gonna be increased, and it's gonna be shrinking. All right. But theoretically speaking, it will not disappear all of a sudden. It gradually shrinks. All right. All right, so first diagrams that we're looking at from the respiratory system is going to be a 5 stars diagram, highly important for us. It's the diagram showing the upper respiratory center, upper respiratory system. So all markings are highly important. I believe there is nothing on the diagram which is not clear. So the nostril, nose, nasal cavity, the concha, myitis, nasal vestibule, hard palate, soft palate, tongue, lingual tonsil, hyoid bone, larynx, epiglottis, vestibular fold, thyroid cartilage, vocal fold, cricoid cartilage, thyroid. So all of them are going to be testable. All the markings on this diagram are going to be testable. All right. One of the most common wrong answers that I usually see is people identifying the whole thing on here as the opening of the eustachian tube or the opening of the pharyngotympanic tube. All right, so the whole thing is called nasopharynx. The whole thing is the nasopharynx. The tube, the opening of the tube is just this point right here, just this point. All right. So again, upper respiratory system is a 5 stars diagram. So Martina, I don't understand your check marks. What do you mean? Check marks on here, I'm just making sure that those are easy for you to figure out. So everything is going to be expected from you to know on the test, on this diagram. Everything on the diagram. I was just checking if there was something that we didn't mention before. Another 4 stars to 5 stars diagram. Again, all markings on the diagram here is going to be highly important for us. Vestibular folds, vocal folds, true and false vocal cords. Those are two names for the vestibular fold and the vocal fold. Glottis, trachea, cuneiform, corniculate cartilages, all of them are going to be important for us. A 4 stars diagram. Another 5 stars diagram is going to be showing the conducting zone of the respiratory system. Conducting zone of the respiratory system. Remember, trachea splits into right and left main bronchi or primary bronchi. Each main bronchus or primary bronchus gonna divide into lobar or secondary bronchi, which will then divide into segmental or tertiary bronchi. All right, remember the right lung has 3 lobes: superior, middle, and inferior lobes, compared to the left lung has only 2 superior and inferior lobes. There is no much to study for this diagram. It's a 1-star diagram. 1-star diagram. Another 1-star diagram is showing, studying you the 2 different types of pneumocytes or alveolar cells. Type 1 alveolar cells, those are the ones responsible for the gas exchange, compared to type 2 alveolar cells. Those are going to be responsible for the production of the surfactant, which reduces the surface tension, preventing the lungs from collapsing. It's a 2 stars or 1 star or 2 stars diagram of low importance. The main things that you need to remember is the different types of pneumocytes or alveolar cells and the function of each of them. A 4 stars diagram, everything on this diagram is going to be testable, showing the relationship between the lungs and the surrounding organs, esophagus, blood vessels. Again, one of the most common wrong answers I usually see is that people consider any blue vessel on here as a vein. So if I'm marking here, this blue vessel, this is gonna be my pulmonary artery or vein. What do you think? Anybody still here? Pulmonary artery, exactly. This is one of the most common wrong answers I usually see, that people, whenever you see blue color on a diagram, you consider it as a vein. All right, so in this case of the lungs, it's going to be an arch. A 10 stars diagram is going to be the lungs, volumes, and capacities. Again, as we've discussed last class, you might have 2 different types of questions asking about the lungs, volumes, and capacities. First type of questions is to ask you to identify the volume or capacity on a diagram like this. You're going to need to identify, this is the tidal volume, this is inspiratory reserve volume, this is expiratory reserve volume, this is my residual volume, all of them together, total lung capacity, inspiratory capacity is both tidal volume and inspiratory reserve volume. Vital capacity is inspiratory reserve, tidal volume, and expiratory reserve volume. Functional residual capacity is going to be expiratory reserve volume and the residual volume. So if you see on here, identifying the different lungs volumes and capacities on the diagram is going to be highly important. Also, to be able to calculate any of them from a diagram. So you're going to be looking at the highest point, the lowest point. So for example, if I'm looking at respiratory reserve volume, I check the highest point on the graph, I check the lowest point on the graph, and I will be subtracting them from one another, getting the volume. You don't have to memorize the normal volumes and capacities, but you need to be able to read the value for each of them from a graph. All right, you don't have to memorize again the lungs volumes and capacities, the normal ranges of the lungs volumes and capacities, but you need to be able to get the value, calculate the value from a graph that will be provided to you, like what we've seen last meeting. Looking here at the blood chapter. In the blood chapter, if we're looking on here, you need to be able to identify the different blood cells from their histological appearance. This is a very important thing. So you need to be able to identify neutrophils, identify eosinophils, basophils, lymphocytes, and monocytes, and of course the red blood cells. You need to be able to identify those white blood cells from their histological picture, like what we've discussed previously. All right, so again, blood cells on here, white blood cells, red blood cells are a 10-star diagram. Combined together, all of them gonna have to appear on the test. Another highly important diagram that you need to be aware of is going to be the blood typing. Remember, if you do have agglutination reaction, this means that the antigen did meet the antibody. So in the first example on here, you're looking at agglutination reaction with anti-A and anti-B. So this means you are dealing with a blood type that has both antigen A and antigen B on the surface of its cells. It's a blood group AB. Here I have only agglutination reaction, as you see on here, with anti-A. So the blood cells have only antigen A presented on their outer surface. So it's a blood type A. Agglutination reaction only with anti-B. So this means I have only antigen B on the surface of my red blood cells, which will make the blood type I'm testing, it's a blood type B. Not having an agglutination reaction, neither with anti-A or anti-B, this means for me that the blood I'm testing doesn't have neither antigen A or antigen B presented on its outer surface. So it's going to be a blood group type O. The essay question that we're going to have for this upcoming lab exam is going to be addressing the erythroblastosis fetalis. Erythroblastosis fetalis, you're going to need to know the pathogenesis of the disease. You're going to need to know here pathogenesis of the disease. You're going to need to know risk factor, manifestation of the disease, and its prevention. All right, so 4 things on here that you need to remember for the erythroblastosis fetalis, and this is going to be your class activity for today. I will write it down on here for you. Erythroblastosis fetalis. Remember, erythroblastosis fetalis. What was erythroblastosis fetalis again? This is a hemolytic anemia that develops in fetus. And remember, anybody still needs this here, this slide? Pathogenesis, risk factors, manifestations, and prevention of erythroblastosis fetalis. This is again the in-class activity for today, and it's also the essay question for the upcoming lab exam. Remember, if a female is Rh negative, her red blood cells don't have antigen D on the surface. And if she got married to a male who is Rh positive, this means he is presenting antigen D on the surface of his cells. So he might be either having 2 copies of the gene coding for antigen D, or he might only have 1 copy of the gene coding for antigen D. For the antigen T to be presented on the surface of his red blood cells. Remember, in this case, if this female is pregnant, she is Rh negative, the baby is Rh positive. Let's say, why? If she is d small, and the father was D capital, so all his sperms gonna have the gene coding for antigen D, and all her eggs won't have the gene coding for antigen D because she is Rh negative. So all of their children will be D small. This means they have a copy of the gene coding for antigen D, which in other words means all their children will be Rh positive. In this specific case, if the father was having 2 genes to code for antigen D. So will I have any problem with the first baby? There will be no problem, because the immune system of the mother does not get in contact with the red blood cells of the baby during pregnancy. I get no exposure to the D antigen. Remember, D antigen for the mother is a non-self, but there is no exposure to the D antigen during pregnancy. When would I have a problem? Remember, if this baby is born, when this baby gets born, during labor, some of his red blood cells expressing the D antigen on their surface are gonna be traveling to the mother's circulation. So now the mother's immune system gets exposed to the D antigen and starts the production of anti-D. I will start to produce immunoglobulins against antigen D. When the placenta detaches, yes, some of the red blood cells of the baby, also during labor, you're gonna have bleeding from the placenta, as well as cuts in lacerations all around in the birth canal. So this exposes the mother to the red blood cells of the baby. All right, so now the mother got exposed to antigen D from the first baby. This was my first baby who is Rh positive. I didn't have any problem during pregnancy, but during labor, I get exposed to some of his red blood cells. So the mother now is gonna be activating her naive B lymphocytes, and those naive B lymphocytes, if you remember, will become plasma cells. They will start to release anti-D. But the problem that when you activate the naive B lymphocytes, you're not only forming plasma cells, you're gonna also be forming memory B lymphocytes. So you develop immunological memory against antigen T. Remember? Later on, the mother, when she gets pregnant another time, the other baby is gonna also be an Rh positive. So his red blood cells are expressing the D antigen on their surface. But the problem here is that the mother now, she is producing immunoglobulins that can travel through the placenta. They can cross the placental barrier. And if you remember, what is the type of immunoglobulins that can travel through the placenta? Which is the most common type? It's a monomer, only formed of 1 unit, IgG. IgA is the one that gets released with secretions, right? That gets released with secretions. Like in the mother will be given her baby IgA by lactation. All right, but IgG is the one which is a monomer that can travel through the placental barrier. And this monomer will mark the red blood cells of the baby for destruction. And this results in, again, erythroblastosis vitalis, how to prevent this from taking place? We're gonna be giving the mother anti-D ourselves when around labor time. We're gonna be given anti-D for us to destroy the blood cells that might pass from the first baby to the mother's circulation. Why do I give anti-D? This is not something that's going to be permanent. This is not something that will develop an immunological memory. They will remain in the blood for a brief period and then they will be broken down. What I'm trying to do, I'm trying to prevent the immune system of the mother from activating its naive B lymphocytes for it to not develop memory against the D antigen and for it to not produce its own anti-D immunoglobulins. So what I'm trying to do here, I will be given anti-D immunoglobulin D to break down any of the baby red blood cells that did pass during labor to the mother's circulation, preventing the activation of the mother's immune system against antigen T. All right, this is simply speaking the whole story. Any questions? Any questions? All right, thank you for making it to the meeting today. And yes, can you please go back to the last slides, this one here? Yes, the class activity is going to be an essay form, yes. If you want to write it down in points, this is going to be fine. If you want to write it down as a paragraph, this is going to be fine as well. Any other questions for me? All right, thank you so much for making it to the meeting today and have a good rest of your day and stay safe. We'll see you on Thursday. Yes, the review of the essay question is going to be included in the recorded session. Yes. Thank you all, and we'll see you on Thursday.